Welcome. My name is Todd Valines, and I have the privilege of being the chair for this year's SCCT 2025 Young Investigator Award competition. I want to first off welcome all of our presenters. We are very fortunate to have 5 finalists presenting to us today, as well as our Young Investigator Award Committee, and we have several folks from that committee with us today that I'll just briefly introduce. And for the sake of time, I'll just mention we have Dr. George Wesby from Scripps Clinic Medical Group in San Diego, Dr. Dominique Day from Cedars-Sinai Medical Center, and Dr. Rosemarin Ligendart, who is from the University Medical Center in Groningen. Again, thank you for all of our judges and presenters. Today, as I mentioned, we will hear from 5 different finalists. These were folks who were selected among a large number of submissions. And so it is truly an honor to be in this very select group. All of the finalists have submitted a mini manuscript of their work that has been reviewed by the Young Investigator Award Committee. And I'll just remind folks that the winner and first runner-up of the 2025 Young Investigator Award will be presented at the 2025 Annual Scientific Meeting in Montreal, the SCCT Annual Scientific Meeting. So with that, we will get started. Welcome our additional Young Investigator Award Committee judge, Dr. Kalika has joined us as well. At the end of each 8-minute presentation, we will have time for questions from our Young Investigator Award Committee members. We'll take questions for about 5 minutes, and then we'll go on to our next presenter. So without further ado, let's go right into our first presentation. And I'd like to welcome Dr. Peo Kai. Dr. Kai is from the University of Edinburgh, and she will be presenting her work that is titled Coronary CT Angiography versus Cardiovascular Risk Score for Lifestyle and Risk Factor Modification in Primary Prevention of Cardiovascular Disease. This is work from the Scott Heart 2 IMPACT study. So we'll turn it over to you, Dr. Kai.
Thank you very much. Right. Thank you very much for the kind introduction. I'm absolutely honored to be here today to be presenting to you all the results of the Scott Heart 2 IMPACT study. I have nothing to declare. So, coronary artery disease is one of the world's leading causes of death, and primary prevention is key. At the moment, primary prevention of coronary artery disease requires identifying individuals who are deemed at risk using cardiovascular risk scores, and then clinicians try to optimize these individuals' cardiovascular risk profile by promoting healthy lifestyle behaviors and also prescribing preventative therapy when appropriate. Whilst they're easy and quick to use, 10-year cardiovascular risk scores can be imprecise, as they can often over or underestimate cardiovascular risk, and individuals can find it difficult to understand the concept of risk, meaning that their acceptance for physicians' advice on lifestyle behaviors as well as medication therapy can be variable. CT coronary angiography can accurately detect coronary atheroma, although it is more expensive and more labor-intensive to use. However, we think that it could be used as a more precise screening tool for coronary artery disease. And with this in mind, the Scott Heart 2 trial was designed to compare the effectiveness of CT coronary angiography against the Scottish equivalents of the Framingham Cardiovascular Risk Score, and this is known as the ASSIGN score. This is currently an ongoing open-label parallel group randomized controlled trial that is recruiting 6,000 asymptomatic individuals between the ages of 40 to 70 years with at least one cardiovascular risk factor. Within the Scott Heart 2 Within the Scott Heart 2 trial, we performed a nested sub-study known as the IMPACT study, and the aim of this was to evaluate whether CT coronary angiography guided primary prevention can lead to healthier lifestyles, whether it can improve adherence with preventative medications, and whether it can improve cardiovascular risk factor modification. We recruited patients who are already taking part in the SCOT-Heart-2 trial until we reached a total number of 400 participants. And all patients had their weight, waist circumference, blood pressure, lipid profile, as well as glycated hemoglobin measured. And they also filled in self-reported questionnaires on physical activity, smoking status, and diet. They also received one-to-one lifestyle advice with a clinician, and then they underwent randomization into either getting their cardiovascular risk estimated through the assigned score, which is the risk score, or via CT coronary angiography. For the purposes of the next few slides, I'll be representing data for the risk score arm in blue and for the CT arm in red. For those in the risk score arm, if they had a risk score of more than 10 or equal to 10%, then the recommendation was for them to be started on lipid-lowering therapy. And for the CT arm of the study, if they were identified to have disease, then they were recommended to have lipid-lowering therapy as well as antiplatelet therapy. And at the end of 6 months, they had the same assessments performed and they filled in the same questionnaires. The primary outcome of the study was the proportion of patients achieving NICE recommendations on the composite of healthy BMI, physical activity, diet, and smoking. NICE is a UK-based government body that produces evidence-based guidelines for medical professionals to follow. And the secondary outcomes in our study were components of the primary outcome, adherence to preventative therapy, changes to lipid profile, blood pressure, weight, step count, and cardiovascular risk score. Here are the baseline characteristics of our study. Generally, in our population, the two arms of the study were well matched. I'd like to emphasize that we had equal numbers of males and females in our study. The prevalence of smokers are on the low side, and the total cholesterol tended to be mildly elevated. And the average 10-year cardiovascular risk score came out to be about 14. So let's have a look at the results. So here I'm showing you the percentage of patients who met the criteria for healthy body mass index, physical activity, diet, and smoking. And I'd like to point out that overall, the total number of patients who met all 4 criteria are generally on the low side. However, people who were randomized to the CT arm of the studies were 3 times more likely to meet the primary composite endpoint. Now, when we look at the individual components, we find that generally patients who were randomized to the CT arm of the study tended to display healthier behaviors. Certainly, it's the case for BMI and diet. For physical activity and non-smokers, although we didn't reach statistical significance, overall the pattern shows that CT arm tended to display healthier behaviors. Now, what about medication use? So, in the CT arm of the study, patients were more likely to be recommended fewer recommendations for preventative therapy. And when we focus on the acceptance rates of these patients, in the cardiovascular risk score arm, half of these patients were accepting of treatment, whereas for the CT arm, 3/4 of these patients were accepting of therapy. So overall, CT angiography led to fewer recommendations to preventative therapy, but greater patients' acceptance with preventative treatment. Now, what about cardiovascular risk factor modification? Here I'm showing you the violin plots that are demonstrating the changes in LDL cholesterol. On the left-hand side, we have the results for the risk score arm shaded in blue, and on the right-hand side, we have the CT coronary angiography arm. The violin plot in navy represent the high-risk group arm, and the one for red represents those who are identified to have disease on CT. And we demonstrate that identifying coronary atheroma on CT angiography led to greater reduction in LDL cholesterol. Now, when we have a look at blood pressure and weight, we saw similar changes. And with daily step count, we found that in the group that were found to have atheroma on CT, they tended to display higher number of daily step count. And this is more an accurate measurement of physical activity rather than patient self-reported questionnaires. Now, the combination of greater cardiovascular risk factor modification as well as greater acceptance in preventative therapy led to a reduction in overall cardiovascular risk in the group that were randomized to CT arm. Now, last but not least, you might be wondering whether we reclassified any of these patients. So if we look on the right-hand side of the alluvial plot, in patients who were found to have normal coronaries, 1 in 2 of these patients initially had a cardiovascular risk score of greater than or equal to 10%, meaning that these patients would have been overtreated. On the other hand, 1 in 5 patients who were found to have atheroma on CT initially had their cardiovascular risk score of less than 10%, meaning these patients would have been undertreated. And overall, CT led to reclassification of 1 in 3 patients. Ladies and gentlemen, I'd like you to remember from my study that compared to standard cardiovascular risk score, the use of CT angiography was associated with better compliance with healthier lifestyles, fewer recommendations for preventative therapy, but greater patients' acceptance with preventative treatment. And it also led to improved risk factor modification in cardiovascular risk score. I'd like to sincerely thank my colleagues, Dr. Michael McDermott and Dr. Mohammed Mia. Without them, none of this would have been possible today, and my supervisors, Professor David Newby and Professor Michelle Williams, for their support. Thank you very much, and I'm happy to take any questions.
Excellent. Well, thank you so much for that very, very interesting and educational presentation, and congratulations to you and all of your co-investigators on this really important study that we'll continue to learn from, and that is the Scott Hart 2 study. So at this point, I'd like to open the floor to the Young Investigator Award committee members who may have a few questions for you about your work. So I guess one question, you showed that, and I'll ask maybe the first question is, why do you think this was the case? Was it, how was the data from CT presented to patients? Meaning, how did patients learn about their CT findings? And maybe you could also describe just the overall burden of disease in this population. This is a screening population.
Yes. Yes, so I like to emphasize that these are all asymptomatic patients, a screening population. And within the CT arm, we found that half of these patients were found to have normal coronaries. So 9% of these patients were found to have obstructive disease, and the rest for non-obstructive disease. For the purposes of time, I didn't have enough time to represent the sub-randomization data for the CT arm, but we further sub-randomized them into either getting their results through a visual format or via a verbal report. So half of the patients in the CT arm sat down with a clinician, and we showed them exactly what their coronaries looked like, and we explained the results to them. And the other half were given the results in a scripted manner on the category of coronary artery disease if they were found to have any. And interestingly, we found that it doesn't matter which format you deliver the results, there was no difference in the outcomes.
Great. Yeah, very, very, very interesting. This, this implementation science of how do we then take these results and implement them to lead to change. And I think that's something that certainly warrants more study. So congratulations on that. Yeah. Other questions from the Young Investigator Award Committee?
Thank you for this great study. Sorry, I had a quick question, which I think Todd asked about the review of the images. If the physician had sat down with the patient and gone through the coronary CTA data set, which I think you answered, but was that done in the sub analysis where the patients were shown their images?
Yes, so after these patients had their at the time when they had their CT scan, we randomized them one-to-one into either getting the report visually or verbally. And the ones who were allocated to the visual report arm, we actually brought them into the reporting room and showed them their images and told them, the results. For the verbal report arm, we spent the same amount of time with the patient, but we had like a script and told them, whether they had normal, mild, moderate, severe coronary disease. I hope that answers your question.
Yes, absolutely, sir. And I will
I think we've got time for one more question. I think, Rosemarie, you had a question?
Yes, thank you. Very, very interesting study and excellent work. I was wondering, were these results what you expected? For example, the whole idea of SCOT-HART2 is, of course, to find more people with early disease, but actually, I think a lot of the people were down stratified in risk. Was that what you expected, and what do you expect for the whole study?
So to be perfectly honest with you, one of the limitations of our sub-study is that almost half of the patients were had a greater level of education baseline, and I have to say that our population perhaps tended to represent more of a motivated group per se, because this is more population screening. So it attracts more of the worried well, people who are more interested in their health. However, this is reflective of screening clinical trials, because as much as we've tried to recruit the the baseline population, this tends to be the case. In terms of the results, to be honest, it was kind of as we expected with the CT arm. We were thinking that they would probably display healthier behaviors, and we would find changes in LDL and blood pressure, weight, etc. But the LDL and the total cholesterol surprised us the most because the magnitude of change was quite impressive. To be honest with you, I must admit, a part of me personally thought that I might find different higher changes in the visual arm, because they were, some of the results were a bit more striking. So I thought maybe there was a difference I would find between the visual and the verbal report groups, but there was none. But I think we'll have to wait for the main SCOT-HART2 data to find out whether the changes that we're seeing are sustained long term, and whether it actually improves patients' clinical outcomes.
Thank you for your reflections.
Thank you.
All right. Well, I think for the sake of time, we will move on. And again, congratulations on that excellent first presentation. It is really my distinct honor to introduce our next Young Investigator Award finalist. This is presented by Dr. Ruben Mora. Dr. Mora comes to us from the Lundquist Institute at Harbor UCLA. And Dr. Mora will be presenting his work titled Semaglutide Therapy and Reduction in Left Ventricular Mass in Patients with Type 2 Diabetes, a STOP trial sub-study. Welcome, Dr. Mora.
Good afternoon, and thank you for that introduction. Yes, so today I will be discussing a sub-study of the STOP trial, which in fact did look at semaglutide therapy and the effects at left ventricle mass, and also I'll be discussing any significant changes that we saw with chamber size. So just to start with a little bit of background, we know that LVH is one of the strongest predictors for cardiac outcomes, including heart failure, arrhythmias, and also sudden death. And there's various reasons for that. There's structural and electrophysiological changes that occur in patients with diabetes, which in fact the LVH rates is pretty high and common for type 2 diabetics. So I'm giving this introduction to then go into discussing how semaglutide and other agents also have an impact on the left ventricular mass and chamber size. But some of the contributing factors for why LVH occurs in these patients with diabetes have been attributed to chronic inflammation. There's also hyperglycemic states, which cause formation of advanced glycation end products, as well as activation of the renin, angiotensin, aldosterone pathways, and as well as myocardial fibrosis. So we have various studies already that demonstrate the the effects of GLP-1 receptor agonists on being able to reduce cardiometabolic risk, and some of those cardiovascular outcome trials do show that there is a significant reduction of major adverse cardiac events. So wanted to show this timeline, which not only shows the GLP-1 receptor agonists through these studies, but also some of the other agents that have demonstrated reductions in cardiac outcomes. But I want to point out to the SUSTAIN 6, which was one of the trials looking specifically at semaglutide in its injectable form, as well as Pioneer 6, which is another study also looking at semaglutide in the oral form. Both former one 2016 and then the latter one in 2018 were released, and demonstrating again that there was a significant reduction in the major adverse cardiovascular events, and also showing a confirming a cardiovascular safety profile for these medications. So what this helps establish is that there's it's really solidifies the role of these GLP-1 receptor agonist agents in being able to reduce cardiovascular risks. Now, some of the benefits that these agents have, more so through mechanistic pathways, is that the GLP-1 receptor agonists can help reduce weight loss significantly. And this averages typically from 2 to 6 kilograms up to 8 to 9 kilograms based on some of the studies from the American Diabetes Association, and especially with the higher dose of semaglutide administered. There's also improved benefits in the systolic blood pressures, ranging anywhere from 2 to 4 millimeters mercury reduction. That's from some of the literature from ACC. And then there's also an effect that they have on reducing inflammatory markers such as CRP, TNF-alpha, and also improving or increasing adiponectin, which is a protein hormone released by fat cells. So having said that, that really establishes the biological rationale potentially for why left ventricle mass reduction could potentially favor a myocardial remodeling in agents such as the GLP-1 receptor agonists. But even though there's preclinical models out there and also smaller studies, there's really not a lot of human data. And this is where our study really tries to determine exactly the mechanisms why or how these agents are able to contribute to left ventricle mass reduction and also potentially remodeling. So the sub-studies, like I mentioned from the STOP trial, that initial trial was a randomized double-blind placebo control trial. It lasted about 52 weeks from beginning to the follow-up stage, at which a CCTA imaging was performed both at baseline as well as at the 52-week mark. And the primary outcome that was analyzed for the main trial was looking at atherosclerosis progression, which I won't go into the details of that study. I'm going to be focusing on the results of the sub-study, which is looking at the chamber volumes as well as left ventricle mass changes. So just wanted to give you a brief preview of some of the major inclusion and exclusion criteria, and mainly highlighting that for inclusion criteria, the patients that were included were type 2 diabetics, not type 1. And then also these patients had at least one cardiovascular risk factor, those listed here: hypertension, hyperlipidemia, premature heart disease, family history, and also prior or current smoker. So the initial trial screened 168 patients, 28 of which were excluded based on the criteria mentioned before. And so 140 of these patients were randomized to these two arms, one to the treatment group of semaglutide, injectable form, and the other one to the placebo group. Now, from there were patients that were either lost to follow-up or the studies were excluded for this sub-study based on the imaging that was poor quality and not a good grade enough to be able to analyze. So in total, there were 57 of the patients who were analyzed from the semaglutide group and 54 that were analyzed in the placebo group. And just to give you a context of the protocol that was performed, these were cardiac CT images that were done with a 256 slice machine. That's the GE Revolution. The software we used was a Philips software that allowed for semi-automated Now, the patients were adjusted for all of these parameters: age, sex, BMI, hypertension, as well as looking at their lipid profile and smoking history. The difference I do want to point out that was statistically different was the patient's BMI. So we see that for the placebo group, on average, the BMI was 33.5, and that of the semaglutide group was 30. Now, the main results that we found from this sub-study was that for the left ventricle mass measurements in the within group difference, we saw that there was a reduction on average of about 8.6 grams. And that was compared to the placebo group, in which there was an average increase of 1.5 grams, which comparing those two, there was a mean difference of about 10 grams. And that was the one that was found to be statistically significant, while the other volumes for the other chambers were not statistically significant. So what this leads us to believe is that there may be a selective reduction in left ventricle mass with no changes in volume, which could suggest that there's possibly a pattern of alterations, specifically targeting myocardial substrate, and not so much driven by chamber volume changes, which we typically see with pressure or volume overloads. So the hypothesis, revisiting the mechanistic pathways we saw previously, is that there could be a lot of these effects that are driven by a decrease in inflammation, as well as possible improvement in the endothelial function. And then also there's a change that occurs in the energy utilization by these heart cells. So mainly that there's more oxidation occurring through glucose oxidation through insulin increase and less fatty oxidation, which we typically see with glucagon. So just to compare this trial with some of the other ones out there, the STEP HFpEF trial did not demonstrate a left ventricle mass change. However, that was performed with echocardiography. Ours was done with CCTA, and which has better resolution than echocardiography. There's also a notable difference that our patients were type 2 diabetics with a higher baseline BMI. There's another study, which is the tirzepatide. It's the SUMMIT trial, but looking at tirzepatide and the effects on left ventricle mass, which correlates with our findings that there was a decrease in left ventricle mass as well as pericardial fat. So strengths that our study poses are that we used high resolution CCTA, which has been proven to be as effective as MRI. And then also we looked at these from a blinded perspective, targeting the high risk group, which are diabetics with high cardiovascular risk. However, the limitations include a modest sample size that was not powered to the changes that we were looking at. And there was also no hard outcomes like hospitalizations or heart failure events for these patients. So some of the future items that we're going to be looking at is potentially evaluating longer trials and then also larger trials with better tissue characterization, which could potentially occur with cardiac MRI, mainly looking at strain patterns as well as fibrosis on imaging, and then correlating that with other modalities like echocardiography and MRI. And with that, I just want to list my references and also just thank my lab and also the SCCT for being able to offer me this opportunity. Thank you.
All right. Well, thanks so much, Dr. Mora, and congratulations to you and your entire team of investigators on this excellent work. At this point, what I'd like to do is open the floor for questions from our Young Investigator Award Committee. And so please, committee members, Dr. Day, Dr. Kulik, I see we have a question from Rose Marin.
Thank you for this great work. Very interesting results. I had a question regarding your hypothesis on what is really causing this reduction in LV mass, because semaglutide in itself also results in better glucose levels, reduces hypertension, reduces BMI and overweight, which in itself have an impact on LV mass. So what is your, how can you distinguish whether the effect that you see on LV mass is really due to semaglutide or due to the reductions in weight, hypertension, etc.?
Thank you. That's an excellent question. Yes, that's precisely the goal of this study, at least introducing that question. So part of what we did was we stratified the results to look at any significant changes in mass as well as volumes, accounting for the hypertension, BMI, these patients' age, and then also their smoking history, which based on that multivariate analysis, there still was a significant change. But like you mentioned, the question is, what are the biochemical pathways that are contributing to that? And in part, my hypothesis stems from just understanding that there's, besides managing the glucose better and also hypertension, uh, it's really how the heart cells are able to utilize energy. And in one of the slides, I mentioned how there's myocardial metabolic shifts, which there's more insulin um, being utilized and less glucagon, which in effect it alters the pathways from like more glucose oxidation and kind of less of the fatty acid oxidation, contributing to just a reduced actual mass, but not so much the remodeling effects, which I think you would see more so with changes in or improvement of hypertension.
I understand. It's just that you haven't proven that in your study. So I was wondering, and maybe just give you the tip to also adjust for the delta, the difference in weight and blood pressure, so that you can see if there's an independent effect of semaglutide beyond the effects that you see on the change of these other factors. Thank you.
And I would just add, looking for any interactions between the effect that you saw for mass reduction and changes in BMI, right? Were there patients who had bigger weight loss that also had more mass reduction, or was it completely independent of those changes that that Rosemary mentioned? Dr. Day, question?
Yes, quick question. Thank you for this excellent presentation. So did you consider also the LV attenuation from the same segmented tissue and its change? Because maybe that could give you some information as to the fibrotic component.
Yeah, that's an excellent question. I think in the future study, we'll be looking at that more so with if we are able to use MRI for studies for these patients. We were limited in that our first focus was on looking at the actual coronary lumen and then chamber volume sizes, but not so much attenuation.
Thank you.
I had a quick question for you. I know in some of the studies you mentioned, so for example, the Summit trial, they had looked at changes in pericardiac fat. Is that something that you all are looking at or have looked at? I know that wasn't the focus of your current presentation, but give us some thoughts there.
Right. Yes. So there, from our lab in this study, we have published a separate paper that looked at epicardial adipose tissue, demonstrating that there is a significant change. And then there's also an ongoing study that we have looking at the perivascular adipose tissue and seeing what the effects are. Our hypothesis is that we likely will see some reduction in the perivascular adipose tissue. But what's interesting is that when we looked at the actual degree of like plaque change, there wasn't significant change, although there was a conversion from more soft plaque to or non-calcified plaque to more calcification. So I expect that there's going to be also some correlation with a decrease in that perivascular adipose tissue in those patients who we see some significant changes in from non-calcified to calcified, just indicating that there's inflammatory pathways that are being attenuated.
Yeah, well, great work. I guess my only other comment would be just from, there were some, tends to be in a year-long study that patients being studied oftentimes are, even in the placebo arm, oftentimes behaving differently because they're in your study. And, there is oftentimes with these types of studies, you may need to do some placebo corrected analysis, where you consider that in your event or endpoint reporting, just placebo correction, because you did see some changes with placebo, for example, and for example, I think your left atrial volume and some other things did get better too. So, all right, well, pending no further questions, I think we'll move on. But again, congratulations, Dr. Mora. Impressive work, and thank you again to all of your investigators. Our next presenter, I'd like to introduce Dr. Christos Gizas. Dr. Gizas will be or comes to us from the Lung and Heart Institute in Lille, France, and is presenting work titled Photon Counting CT for the Evaluation of Myocardial Fibrosis and Hypertrophic Cardiomyopathy, a comparison with MRI. Welcome.
Thank you, dear Chairman. It's an extremely honor for me to share our results with just an accomplished researchers. Good afternoon to everyone. So hypertrophic cardiomyopathy is one of the most important causes of sudden cardiac death, and the assessing risk of that is an important component of management for the patient and the family. And despite all the improvements in multimodality imaging, still the true clinical burden of symptomatic hypertrophy is still unrecognized. The extracellular volume is a quantitative method for assessing diffuse fibrosis or edema, and in previous CMR studies has shown excellent correlation in diffuse fibrosis or edema, better even than the late gadolinium enhancement, which is the stepping stone biomarker of the cardiac MRI. We know that LGE more than 50% is associated with increased risk of sudden cardiac death, even if sometimes this cutoff is under debate in the literature. Some recent studies have shown the feasibility and accuracy of calculating ECV from scanners, and especially after the introduction of dual energy CTs, we can directly calculate extracellular volume from iodine maps from late enhancement, thus avoiding additional radiation exposure and minimize misregistration errors. This possibility is further improved since 2021 with the introduction of this new cut-off technology, the photon counting CT. Semi-detector of photon counting detectors offer an excellent intrinsic spectral information and material decomposition, as every X-ray photon energy is measured in different energy bands. So the purpose of this study was to evaluate the accuracy of extracellular volume derived from photon counting CTs in patients with hypertrophic cardiomyopathy and its potential clinical utility compared to the gold standard, the cardiac MRI. We retrospectively included patients we referred to the Harendra Lung Institute for cardiac CT in order to exclude coronary artery disease, and they presented at least one risk factor. Within 24 hours, all patients underwent the cardiac MRI in part of a 48-hour ambulatory hospitalization, which included Holter monitoring, peak VO2, and stress echocardiography. The CTA was performed in a prospective mode, and the late iodine enhancement acquisition systematically 5 minutes after the rejection of 50 ml of the same iodine contrast agent in the high pitch mode. As we don't have a direct and validated method to quantify the percentage of late iodine enhancement, it was very important for us to have a consistency between the late iodine enhancement and the LGE, as you see in this simple example of our daily routine in the workstation. Thanks to the spectral capabilities and the possibility to work in low KV, we can see these areas of patchy fibrosis, excellent correlation with the LGE images. This is a workflow of the ECV quantification with the photon counting CT, which was performed thanks to a prototype software that was provided by Siemens, that generated polar maps according to the American Heart Association, and it had the possibility to create maps for the different layers, the endocardial, myocardial, epicardial, but also for the total myocardium. These results were compared with a classic CMR comprehensive protocol in a 1.5 Tesla. And in order to avoid endocardial and epicardial edges and to match the CT and MRI offset, we chose a 10% offset for the calculation of ECV MRI. The quantification of the percentage of the LGE was in comparison with the percentage of the myocardial mass with the 5 standard deviations, and the post-treatment was performed with Circle. So we include the 30 patients with a genetic test confirmation. You see on the right side of your screen the patient characteristics and the medication overview of the patients included. The mean DLP was very low for the late iodine enhancement acquisition, and the quantification of ECV was feasible for all subjects. The mean late gadolinium enhancement percentage was 6.4%. We found no significant difference between the global ECV-CT and ECV-CMR. The blood Altman analysis showed small mean errors and narrow limits of agreement, and we observed excellent inter-observer agreement for the LGE quantification, but also for the calculation of the extracellular volume for both modalities. We also found strong segmental correlation between ECV-CT and ECV-MRI for the basal, midventricular, and apical segments. A ROC analysis curve was realized with an area under the curve in order to obtain optimal thresholds for predicting LGE more than 50%. And we found that the threshold of 33.4% of the ECV-CT showed very good performance in predicting the severity of fibrosis. Among the different layer-specific ECV-CT thresholds, epicardiac ECV-CT showed the highest area under the curve with 0.86. The Pearson analysis finally showed strong negative correlation of the extracellular volume derived from the photocounting CT with the peak VO2. Here is a classic example of a female patient, and you see respectively for the images A to D, the comparison of virtual monoenergetic images in 40 kV and the comparison with the LGE, but also the ECV-CT map and the ECV-MRI map, showing the very good correlation of two modalities. Another example of apical hypertrophy, here we see the excellent correlation of the iodine map compared to the LGE, but also the respective polar maps of the ECV-CT and ECV-CMR. So this study shows that ECV-CT using photocounting CT is accurate, it's feasible, it can potentially be an alternative biomarker for assessing myocardial fibrosis in patients with hypertrophic cardiomyopathy. It's not the first study that evaluates ECV, but it's the first study in this type of disease. Recently, we have published another relevant paper concerning the role of ECV-CT in myocarditis. And the strong negative correlation of extracellular volume of CT with the peak VO2 also underlines the importance of evaluating all these new biomarkers with more clinical markers, because this is in accordance with the literature that we know that fibrosis is really correlated with reduced functional capacity even in asymptomatic patients. Photocounting CT, thanks to its spectral capabilities, could offer a one-stop examination for simultaneous evaluation of the coronary artery disease, the myocardial perfusion, and the fibrosis, because we should remember that patients with coronary artery disease have significantly worse prognosis when they have also hypertrophic cardiomyopathy. Of course, this is a single-center retrospective study with a modest cohort with no official histologic validation for the fibrosis. Photocounting CT remains not widely available to generalize these results. And actually, in the Harendra Institute of Lille, we work in the second part of this study with arrhythmic endpoints and the quantification of late iodine enhancement similar to the LGE. So in conclusion, ECV-CT with photocounting CT offers a promised non-invasive imaging alternative to MRI. This cutoff technology could facilitate the multimodality evaluation of disease progression and response to therapy in HCM patients. And I think that most of you have already read this excellent paper, how we envision cardiac imaging in 2040. We wait lots of developments, but now already in 2025, CT is already like more MRI thanks to photocounting CTs. Thank you for your attention, and I'm happy to have your remarks and your questions.
Well, thank you for that excellent presentation, and congratulations to you and all of your investigators for this great study. We're going to open the floor now to questions from our Young Investigator Award panelists. And I think the first one is from Omar Khalik. Dr. Khalik.
Hi, how are you? I have one comment which you could discuss and one question. My comment is that in your intro slides, you said that there's no increase in radiation, but I think most of the protocols, including yours, include the 5-minute delayed image, which does have some increase in radiation. I don't think it's been figured out yet on how to do it on the baseline images. And my question, which was one small point on your graphs, is that you showed that MRI T1 actually had a better AUC than either ECV calculation. And that's one big point of debate in the MRI community, is what is really the additive value of ECV? So my question to you is, do you think there's an additive value?
Thank you. This is an excellent question. I think that is mostly attributed because the fact as T1 offers a mixed signal of cellular and interstitial of the myocardium, has a better probably performance in detecting focal fibrosis compared to the ECV that is better in the extracellular expansion. That's probably explains the relatively better performance of the area under the curve of the T1 compared to the ECVCT, in my opinion.
Can you, this is Todd Valines, can you also comment on the issue that was raised about radiation? I don't know if you looked at your radiation doses. And then second question is just about devices. Did your, one of the challenges we know in imaging, both for the cardiac, measurements as well on MRI, is devices. Did you have devices in these patients? And if so, how did you handle potential artifacts that are seen in those patients with both modalities?
Thank you very much for the question. Depending your second question, no, we didn't have devices in these patients, but in the previous article that we published concerning the role of ECVCT in myocarditis, some patients had, because they are hospitalized, had some epicardial catheters or other devices. So thanks to the possibility to have different energies and iodine maps, but also adapt also the slice thickness in 5 or 6 or 4 millimeters and have different energies, reduce significantly the artifacts, and it was always consistent, the visualization of late iodine enhancement with the LGE. And concerning the first question of Dr. Mark Khalik, thank you also for this very interesting question. Actually, we don't see, concerning the coronary CTA, the cardiac CT acquisition, we don't see a significant reduction of radiation dose. However, the radiation dose of the late enhancement, 5 minutes after rejection, is very low compared to similar modalities. And the total is important because for young patients less than 45-year-old, we just need to have just 2 acquisitions with no calcium score. And the total DLP, I just didn't mention it for the economy of time, did not pass for all patients more than 300 DLP for the 2 acquisitions.
Great, thank you. We have a question from Dr. Liegenhart.
Hello, thank you. Very interesting results. I was more thinking about the generalizability of your results, because is this now particularly due to photon counting C2, or could you get these results maybe with a different cutoff value for any other spectral scanner?
Thank you for this excellent question, Professor Liegenhart. I think that, of course, third generation dual energy CT has already shown this capability to calculate with accuracy and feasibility the extracellular volume. However, previous studies, even one photocounting study, didn't compare these results with other biomarkers, and especially the percentage of LG. The photocounting CT offers probably the possibility to evaluate more precisely the late also iodine enhancement compared to the LGE that different previous studies and third generation scanners didn't do it. And this is study compared, for example, to the previous study that we published in myocarditis, had no other biomarkers included. This study had also much more biomarkers. So I think that photocounting CT, yes, offer this possibility.
Okay, thank you. I think I also saw that you needed less iodine contrast, because we're used to about 150 mil and you only gave 100. So maybe that's also one difference, but thank you.
Well, again, congratulations and thank you for this excellent presentation. We're going to move on now to our next presenter. I'd like to welcome Prerna Singh. Prerna comes to us from Case Western Reserve University in Cleveland, Ohio, and is presenting the work that is titled Low Density Coronary Calcium Below the Agatston Threshold on CT Calcium Scoring Independently Predicts MACE Risk. Insights from Clarify and Scott Hart.
Thank you. All right, so good afternoon, everyone. My name is Prerna Singh, and I'm an MD PhD student at Case Western Reserve University. Today, on behalf of my co-authors and I am excited to present our work on low-density coronary calcium on CT calcium scoring, independently predicting MACE risk. So why was 130 Hounsfield units chosen as the Agatston scoring threshold? Well, in 1990s, when the Agatston score was derived, electron beam CT was used for coronary artery calcium scoring. And this is single slice and highly noisy. So the threshold was wisely set at 130 Hounsfield units to suppress artifact and also ensure reproducibility. But when we fast forward to now, routine calcium score exams are done with multiple slice CT with 64 plus detector rows, sub-millimeter detectors, as well as using iterative or deep learning reconstruction. And this has vastly improved image quality and also decreased image noise. However, the coronary artery calcification detection criteria has not changed. So any calcification with Hounsfield units less than 130 is ignored. On the right, you can see a zoomed in portion of a CT calcium score exam with an overlay of 130 Hounsfield units shown in red. In blue, we've identified certain sections that might have lower attenuation calcium, and this could be a prognostic signal that we could be missing. So for a little bit more background on calcium scoring, the Agatston score from calcium scoring is still the single greatest predictor of major adverse cardiac events. It quantifies coronary artery calcifications that are above 130 Hounsfield units. And it multiplies the calcification area by a density weighting factor, which increases with increasing calcification density. However, recent studies have shown that there's actually a calcification density paradox, where for calcifications above 130 Hounsfield units, there's actually an inverse relationship between CAC density and MACE risk. Furthermore, CAC density is also highly correlated to patient age. So for example, for a 45-year-old patient with a low or reassuring Agatston score, it's possible that they have these lower density calcifications that are inherently higher risk. So in this study, we seek to answer the question, could calcium below the 130 Hounsfield unit threshold add complementary information to the Agatston score for MACE prediction? So when we look at the progression of atherosclerosis, which starts with the normal artery, then we have calcium seeding in lipid pools. Next, we have spotty or heterogeneous plaques that are actually at risk for plaque rupture. And lastly, we have stable plaques or macrocalcification. The Agatston score actually quantifies this last stage of stable plaque or macrocalcifications. So in this study, we think by reducing the Hounsfield unit threshold for detection, we could actually identify image evidence of these spotty or heterogeneous plaques that are at risk for plaque rupture. So to do this, we introduce the Vulnerable Calcium Index, or VCI, on CT calcium score exams. What we do is we take Agatston calcifications and use image processing to region grow them down to 110 Hounsfield units. So on the right, we have a zoomed in portion of a calcium score exam, and we have the 130 Agassiz calcifications shown in red. Then we use our 3D region growing algorithm to extend this down to 110, looking at the adjacent pixels surrounding the Agassiz calcification. Then, to derive our vulnerable calcium index, we use the well-established calcium mass score, which uses a calibration factor to convert Hounsfield units into milligrams of calcium. We compute a % change in mass score when we include calcifications from 110 and above compared to the standard 130 and above. And then we log transform it because we're using linear Cox modeling, and we also add the 1 so we don't have a log of 0. And this is how we derived our index VCI. So given the improvements in CT image quality and also the growing recognition of plaque composition and risk assessment, in this study we introduced VCI and we evaluate its prognostic ability for MACE in 2 separate study populations. The first is the Clarify Registry, which is a no-charge calcium scoring program where patients have at least one cardiovascular risk factor and no prior cardiac disease, so a screening population. The second is the Scott-Hart clinical trial, which assessed whether adding coronary CT to patients with suspected angina improves outcomes. So these are potentially symptomatic patients that might have had prior cardiac disease or interventions. Next, we do the standard calcium score analysis to annotate Agassiz calcifications. And then we use our 3D region growing algorithm, which is an automated method to iteratively extend Agassiz calcifications down to 110 Hounsfield units using 26 voxel connectivity. And then I use the formula as explained previously to calculate VCI for every patient. So here are the baseline characteristics of our study populations. The first is more of a real-world study in Clarify, which therefore does have some missing data. And we also have the Scott-Hart clinical trial with about 1,000 patients with suitable CTs for this analysis. Overall, the populations were similar, but the main differences were that the Scott-Hart patients were younger, more likely to smoke, and on more preventative medications at baseline. However, they had lower Agassiz scores with an overall similar MACE incidence. And this is because we used a MACE-enriched subset of Clarify for this study. So moving into results, we stratified VCI high and low based on the 75th percentile. And here we're plotting the % of patients with high VCI across Agassiz scoring categories. So as you can see, high VCI spans every Agassiz score category. And for example, in patients with lower Agassiz scores of 1 to 100, about 15 to 20% of them actually do have high VCIs. Next, we used VCI alone to stratify MACE risk. So we used VCI of 0, shown in green, low and high VCI, and we looked at MACE-free probability over time. As you can see, there's statistically significant separation when we use VCI alone for MACE risk stratification. Next, we created comprehensive models to add in clinical factors to VCI for MACE prediction. The clinical factors included age, sex, diabetes, hypertension, smoking, and the Agassiz score, and we plotted quartiles of predicted risk for these patients. And when we look at the highest quartile of risk compared to the lowest in Clarify, we can see a hazard ratio of 27, which indicates incredible risk discrimination. And for Scott-Hart, the hazard ratio was 23 when we looked at the highest to the lowest quartile of patient risk. Then when we looked at the adjusted hazard ratio for VCI in these models, the hazard ratios remained statistically significant with 1.12 and 1.17, and this was for a continuous VCI. And lastly, we compared using Agassiz alone compared to Agassiz plus VCI in both cohorts as well as in age-based subgroups. And for each of the rows on this table here, you can see that there is an increase in C index when we include VCI. And all but one of these actually had a statistically significant difference when we added VCI to the Agassiz alone model. So this indicates that we can significantly improve MACE discrimination compared to Agassiz score in 2 separate cohorts. So in conclusion, we created a metric called VCI, which adds prognostic value beyond clinical risk factors in the Agassiz score. And because it can be automatically computed in less than 1 minute per case, it can be seamlessly added to clinical workflows. And in the future, as CT systems continue to improve, we believe that VCI's prognostic signal may prove to be even stronger. So I'd like to thank my lab, collaborators, as well as SCCT for this opportunity. Thank you.
Excellent. Well, thank you so much for that fantastic presentation. And again, congratulations to you on this great work and to all of your co-investigators. I'd like to open up the floor for questions regarding this presentation. Dr. Kalik.
Hi, congratulations. That was terrific.
Thank you.
How did you choose the threshold of 110? And did you see any calcium that was at a lower threshold than that even?
Yeah, so we did kind of like an empirical study where we actually evaluated going down by 5 Hounsfield unit thresholds. And 110 was where we felt confident that we weren't picking up on any imaging noise or kind of combining calcifications. So it was an empirical kind of threshold, and we feel pretty confident that using this threshold, we are picking up calcium. But there was definitely calcium below that threshold as well.
Great. Dr. Flickenthorpe? I believe you had a question.
Yes, thank you. Very interesting presentation, and calcium score, of course, is always a very important topic. I was wondering, you used, I think, the original scan images, which are 2.5 or 3 millimeters. But I was wondering, because with partial volume effect, you will also have this lower density for smaller calcifications that would indeed be beyond 130 Hounsfield units. Would you have looked at the thin slices? So what was your motivation to use these thicker slices, which are, they were originally based on EBT, which just acquired 3 millimeter slices. So was there also an idea to use the thin slices?
Yeah, so using thin slices would definitely be great. So right now what we're doing is we're using the known Agassiz calcifications that were already annotated and region growing them out. So if we wanted to identify calcifications that never met the 130 Hounsfield unit threshold, I think using those thinner slice thickness images would be great. Right now, our lab is basically working on opportunistic assessment of CT calcium score images. So using what is currently done to try to create better risk models. So that's why we're using kind of the standard. But of course, for different studies, we can definitely look at thinner slices and kind of see if we're able to identify them on thinner slices and then also able to identify them again on the thicker slice images.
Thank you. Very interesting.
Yeah, really, really interesting work. I guess one question that I had was, going back to your methods, the question about how did you, did you look at the alternative, which would just be using a lower Agatston threshold, right? Did you compare your mass approach to just saying, hey, let's just do an Agatston score using a lower threshold?
Yeah, so we can definitely do that. And I think the goal here was to look at kind of like lower calcification components and compare that to the typical Agassiz score so that it could be like more of an independent metric. When you look at calcium mass that's below that 130, because it is a mass score, that lower density makes it like there's not as much calcium. So therefore, compared to patients with an Agassiz score of 100, if we're using mass directly, it's not going to be that big of a difference. So that's kind of why we did this metric that takes into account both the Agassiz calcifications as well as the lower ones.
I got you. And I guess my second question would be, other investigators, particularly from MESA, have looked at, difference in how you assess the score, looking at mean versus peak density. And there's some other thoughts to consider as you kind of work on optimizing, if you will. And I guess my last question would be, the question is, are you overcalling, calcium? Because that's always the fear, particularly in noisy scans. And so my question would be, in those patients such as Scott Hart, where you have CT angiography, did you do any, query as to what, in fact, you are measuring?
Yeah, so I think that's a great point and will definitely be an area of further research because we do have those kind of paired CTAs as well as the CT calcium scores to try to figure out, are we identifying vulnerable plaques? Are we actually, like, what exactly are we picking up? We also have an opportunity with the Clarify registry because we have repeat scans every 5 years. So we can look directly at the lesion beforehand and see if that actually progressed. So right now we're looking at it kind of as an opportunistic biomarker, but I think in the future we definitely have more opportunities to make sure what we're capturing is actually calcium.
Dr.
I have a
Westby, I
quick-
believe. Yeah, Dr.
Sorry,
Day and
go
then
ahead.
Dr.
Sorry.
Westby, quick questions.
I just wondered if you had any correction factor for KVP, which is not 120.
Not at this point. We're definitely working on a full like image harmonization pipeline in terms of noise, KVP, and kind of correcting for that attenuation differences when it's changed based on BMI. At this point, we don't have that, but we were pretty excited that our results were pretty consistent without any correction.
Thank you.
Great.
George here, congratulations. This is a great area of research. Is any of your work based on phantoms? The original mass paper by McCullough in 2007 used, of course, the QRM phantom. Is any of your work using phantoms?
So not here. We did do an analysis looking at instrumentation blurring using a previously measured point spread function, just to see what amount of this VCI that we're picking up might be due to this instrumentation blurring. And we did find that after doing computer simulations, the effect was minimal. But I think using phantoms in the future could definitely be a way to kind of strengthen the analysis again. So thank you.
Well, thank you again, and congratulations to you. Excellent presentation. And we're going to move into our final presenter. It is my pleasure to welcome Dr. Kenneth Chan. Dr. Chan comes to us from Oxford in the UK, and he will be presenting the work titled Coronary Inflammation Predicts Cardiac Risk in Patients with No and Moderate Coronary Calcification.
Thank you for the kind introduction, and it's an absolute honor to present. I have no disclosure to declare. As we heard over 30 years ago, seminal work by Dr. Eggleston first described the use of coronary calcification detected on CT as a marker of atherosclerosis. This has a strong prognostic value for cardiac events. An elegant cohort study showed that it is very useful to guide statin treatment. However, long-term follow-up data in the modern era show that patients with zero calcium score are not entirely free from events. To put this into clinical context, let me tell you about Mr. J, who is a 53-year-old gentleman who's active and have little risk factors. Over the years, he had several cardiac CT to investigate for atypical chest pain, which initially showed no coronary calcification and minor calcification on the repeat scan. However, only a year later, he presented with acute coronary event, resulting in significant morbidities. This highlights the unmet need for further risk stratification to help patients like him. Translational studies show that perivascular adipose tissue not only plays a paracrine role in the vascular function, it is also a good biosensor of vascular inflammation. And this can be non-invasively mapped on routine cardiac CT scans, and Phi score can then be calculated to quantify coronary inflammation. So in this study, we include 19,000 patients from the orphan study who underwent clinical cardiac CT scans. It covers an ethnically diverse population. Coronary calcium score and luminostenosis were extracted, where plaque quantification and Phi score for coronary inflammation were analyzed using machine learning approach with Carey Research platform. The cohort was followed up for cardiac mortality and MACE, including MI and cardiac death. So the first research question is the prognostic value of coronary inflammation in the context of calcification. In the whole cohort, coronary inflammation significantly stratified the risk of cardiac events, where patients with Phi score above 90th centile have 6 times higher risk of cardiac mortality compared to the lowest 25th centile. And Phi score remains independently predictive after adjusting for calcium score. In the ROC analysis, it showed significant improvement in prognostic performance by adding Phi score to calcium score, with the area under curve improved from 0.76 to 0.82. From the plaque quantification, non-calcified plaque volume only marginally improved the predictive performance over calcified plaque volumes, but the AUC significantly improved to 0.79 after including phi score. Among individuals with 0 calcium score, patients with phi score over 75th or 90th centile progressively showed increased risk of cardiac mortality compared to those with the lowest inflammation. And this is similar amount patient with mild or moderate calcification. In comparison, the trend diminishes with very heavy calcification, and this is likely due to the very dense and stable calcified plaques. These findings are very similar for MACE with MI and cardiac death. So the next question is whether identifying luminal obstruction is enough amount patient with calcium score of 0. In this group of patients, we observed comparable MACE event rate as previous cohort studies. And among all the MACE events that occurred in the follow-up period, only a small proportion of patients have severe stenosis at baseline scan. In fact, majority of the events occurred among those with no or minimal plaque. So this leads to the question if inflammation could help to stratify the risk in this early atherosclerosis. Indeed, patients with over 90th centile of phi score demonstrate 10 times higher risk of cardiac mortality compared to the lowest 25th centile. And the trend is very similar for MACE outcomes. In a subgroup analysis, mean phi score showed significant prognostic value across different age, sex, ethnicity groups, and the presence of risk factors. And importantly, phi score showed a strong prognostic value among patients who were not previously treated with statin. And the findings are consistent regardless of which coronary artery were analyzed. To put it into clinical practice, we have to consider the whole patient as a whole. And to assess the global risk of the patient, AI risk model that we previously described integrate clinical risk factors such as diabetes, hypertension, and hyperlipidemia, together with plaque burden and coronary inflammation to evaluate the overall risk. In this cohort, by capturing the inflammatory risk, AI risk classification outclassified 30% of the patient compared to clinical factor-based assessment with Q-risk score. And this significantly identified vulnerable patients with cardiac mortality and MACE event in the follow-up. If these tools assessments were available for our patients, perhaps we could detect the problems earlier, identify elevated inflammatory risk, and start timely preventative treatment before the significant cardiac events. So in summary, coronary inflammation is an important driver for early atherosclerosis, and it precedes plaque formation and predicts long-term cardiac outcomes. Coronary inflammation measured by phi score can identify vulnerable patients even with no or minimal coronary calcification. An AI risk model that takes into account coronary inflammation, plaque, and risk factors captures residual inflammatory risk, and this allows us to plan for early preventative treatments. I would like to thank my mentor from Oxford, the collaborators for the orphan study, and thank you for your attention.
Excellent. Well, thank you so much, Dr. Chan. And again, congratulations on your selection as a Young Investigator Award finalist, and congrats to all of your co-investigators. At this time, I'd like to open the floor for questions for Dr. Chan on his study. And yep, Dr. Blickenthart.
Yes, thank you for this excellent presentation. Very interesting results. I have two questions. One is, you go from calcium score 0 to the impact of looking at the FAI score. But normally we do a coronary CTA as part of the examination. So if you really want to maximize the potential of an FAI score, you would have to do it on a non-contrast CT scan. Is that possible?
So thank you for the excellent questions. So at the moment, the FAI score is derived from the contrast phase, and that looks at the perivascular adipose tissue, and that's how the score was initially developed. But of course, with the further standardization and calibration, it could potentially work on the non-contrast phase, although the resolution of the non-contrast phase will be quite different, and it would need further training of the perivascular segmentation and what sort of what the results means from a non-contrast phase, and this is the ongoing work that's definitely for future application on the non-contrast scans.
Right, thank you. And my second question is, so we know that in those who have a calcium score 0, that of course there is some subdivision into those who may have non-calcified plaque or even a non-calcified plaque with stenosis.
Yeah.
If you look at that, the prognosis in those subgroups, is there any additional value of doing the FAI score? Thank you.
Thank you. So actually, from the data, we found that among patients with 0 calcium score, CT angiography picked up only a very small proportion of patients with significant stenosis or obstructive coronary disease. So that's 0.4%. So this group of patients actually further undergo aggressive interventions and preventive treatment, and they didn't actually contribute significantly to the events that we see in this study. Majority of the events that occurred in calcium score 0 were actually those with no significant coronary obstruction, and this is one of the unmet needs really to address the risk for these patients with no or minimal plaques on the initial CT angiography, and that's where the added value for identifying the vulnerable patients with inflammatory risk and for a personalized treatment.
Thank you.
So excellent work. I had one question about, in your analysis, you seem to, it's really the 90th percentile where you saw the biggest discrimination between those with and without events within the calcium score of 0. I have two-part question. Number one is, what proportion of patients actually were above the 90th percentile who had a calcium score of 0? I mean, is this a common finding, or is this a pretty rare finding? And the second question I had to do with, what did you see, what proportion, I think you showed this data, but I want to go back to it. Was there incremental benefit for predicting events compared to the non-obstructive atherosclerosis, such as things like non-calcified plaque burden, high-risk plaque features?
Yeah, thank you for the question. And in fact, we do see a significant portion of patients with the coronary inflammation, the PHI score above 75th and 90th percentile in the calcium score 0 population, and that significantly captures the number of events in the high inflammation group. As to the second question of added value of the coronary inflammation in this population. From the data we've shown of quantifying non-calcified plaque, it has good predictive value of outcomes, but adding mean PHI score to non-calcified plaque quantification significantly improved the predictive value. If I may show some of the results, that addition of PHI score on top of non-calcified plaque quantification significantly improved the predictive value as well as the calcified plaque volume prediction.
Okay, great.
Just a quick question. Did you have any incremental value over epicardial fat characteristics in the same population?
Well, thank you for the great question. So in this study, we didn't include the epicardial fat because that is also included in the in the analysis of the FAI for the coronary events. So we didn't include the visceral obesity metrics in this analysis.
Thank you.
All right. Well, seeing no further questions, I think this will conclude our questions for Dr. Chan. Again, thank you so much for your excellent presentation, and congratulations to you and all of your co-investigators on this terrific work. For those of you in the audience, I would just remind you all that we will, at the 2025 SCCT Annual Scientific Meeting in Montreal in July, we will announce the winner and first runner-up. I would just like to finish by congratulating all of our presenters for their really outstanding work based on the very high number of submissions. It is really just an honor just to be in this very select group. We also had one presenter unable to present today due to a family emergency, but I'd also like to congratulate Dr. Harendra Kumar, who was a finalist, was our 6th finalist, and was unable to present his work titled AI-based automated detection of coronary artery calcium accuracy and clinical utility, but hopefully that will be presented at the SCCT, as will all of these great submissions also be presented as part of the overall just body of great work that we see every year at the SCCT Annual Scientific Meeting. So in closing, I'd like to again thank all of our presenters, all of our attendees, as well as the SCCT for putting together this great forum, and for the sponsor, Canon, for providing the support for this program.